Hello everyone, it's an honor to be with you. My name is Jim Gallagher. I'm the director of the Burn Center at New York Presbyterian Hospital and Weill Cornell Medicine in New York City, Manhattan, and our Burn Center is very close to this icon of New York City, the Empire State Building. I have nothing to disclose, and in this plenary we're going to be discussing improving burn care in rural, remote, and resource-limited health centers. I'm going to go over 5 main points that I think are a good guide to trying to make progress in this setting. Point 1, do not devalue the care you are visiting. So both of these little girls are alive, and the burns were quite a while ago. And so this required a team of people dedicated to help these children, their family, the community, resources, and others. And any building you do to make progress, you're going to need them. And so be sure you help them in the process and value their dedication that is shown in the lives of these 2 people. Point 2 is that you must learn about their customs, their beliefs, their common practices in both the facility and the community. On the left there is a picture of myself and one of the senior nurses at a burn center that I visit in Tanzania, just talking about burns in general and obviously having a laugh. On the screen you'll also see different things that I've come across, everything from aloe to bleach, Mebo, rabbit hair in the lower right, and cassava flour are all among things that you'll find and I think are worthy of discussion because they're in use in the communities that you'll be visiting. And in truth, rural remote staff are often not deeply educated in burns, but rather are generalists whose burn care practice is a mix of what they learned in professional school with the local customs. Point 3. Review things together, the wounds that they have on the ward, looking at photographs, and reaching an agreement. Discuss things and make sure that we all are in agreement on wound healing concepts. Things like first aid, and then importantly separate that from wound healing. Oftentimes people are very married to whatever it is that in that community they put on a burn. But if you separate out first aid, I think they're more often willing to assimilate the idea that first aid is truly different than wound care and things that are put on for healing. Also, we need to agree on a vocabulary. I learned that at my own burn center as the nurses in my center and I went over photos and we talked about what things were. Talk about stages of healing and the normal timeline, what dead tissue means, and bacteria. And then this is all a foundation where you can begin to talk about products, things they're using, what they might change to if they're interested in change. Okay, and really what do wounds need? Think about the differences between clean and moist wound healing versus dry wound healing, which is, I'm sure, going to be common in their environment as it is in ours. Point 4 is really suggesting sustainable options for rural, remote, resource-poor burn care. And you know, this little one is actually in a free form of burn care. So is there anything free? Well, she's getting it. She's eating, her burn is on her bottom, and she's under a cage that looks like this. This is for sale now, something I pulled off the internet. It's the GCC Simmons Gray Burn Cage for Hospital, and this was actually for sale in India. And you know, translated it's $50 US, and I think it's important to recognize this at burn care, what's its strengths and weaknesses, discuss it like you're going to discuss all the other modalities in a serious way, because this actually is a form of burn care that's all over the world. Point 4, continuing on the same idea of sustainable suggestions beyond the cage. The qualities that make something sustainable really are it's either locally sourced or there's a very reliable supply chain. It's got to be affordable and felt to be efficacious in general and certainly by the users. And you know, it's good to take a look at what the price point would be in their market versus other common goods that people are going to buy. This is a picture of a banana grove, and there's a similar banana grove, although on a hillside next to the Tanzanian burn center that I visit. In fact, Mwanza, Tanzania, after moving away from cage and desiccation treatment, really moved into banana leaf dressings, sometimes with topicals, sometimes without topicals, depending on the family who ends up supplying a lot of the burn wound care treatments. And this is a photo of our head burn nurse in Mwanza, Tanzania, preparing the banana leaves for sterilization and use on the ward. And so Banana leaf dressings is discussed in the literature, and I think this is important to share with them and go over what the literature knows about banana leaves. They can go on and write about it, and this is the QR code to access the article. Elsewhere, you'll find other things, I almost feel like up the chain, say, maybe away from banana leaves. India has a history of banana leaves and is actually responsible for most of the literature. But these days, I hear more about these collagen dressings, bovine collagen dressings. However, they are produced in India, so they're locally sourced, and they're very competitive from a price point perspective. And in Brazil, in the last few years, they've made a lot of headlines with the use of fish skin. In fact, here in New York, I was interviewed by our local radio or news outlets about what was going on with fish skin and would it be useful in our patients. And again, as I think about Tanzania and say they were wanting to move beyond banana leaves into something else that might have benefits to them, what would be next? We want to discuss each thing, like the collagen from India and the fish skin, and what might work in this area of the world, and including a discussion of the commercial silver dressings that they're going to see in their unit, oftentimes in a closet as donations, really going through that closet and discussing all the science or lack thereof between all the different choices. And so point 5, in modern times, everyone has a phone, and these days there are actually now EMRs, electronic medical records, that can house photographs for teams to reflect on. And so if you've ever made rounds anywhere without photographs, it's always difficult to see all the wounds with dressings off. And this is, no easier in a lower resource setting, and it requires a lot of time and planning. And patients or staff members I've often seen are running to get their phones, flipping through, trying to show you a picture of something. Well, this is easily supplanted by adopting one of the new EMR phone-based apps that have photo capability and are also useful for triage and transfer. So working with a resource-limited remote place, triage and transfer I think is going to be the last important point to cover. And so it's affordable, it's widely available, but what is the capability that they're going to be sending to? What's the quality of care? Can they get there? Is it affordable for the average citizen? And so what is the capability of this higher level center? In the resource poor setting in general, I kind of think of burn care places in 3 different ways. So where are we sending? Where are you now, and what are you sending to? An RN burn care unit. So really there's just not a lot of physician input, definitely no surgery going on, but a lot of good care by nursing, easing the burden of disease for a huge number of people who don't need surgery, improving outcomes, and providing hope to that group. Up from that, I think of when you have a physician who's making occasional participation, maybe rounding every once in a while, and has a history of providing skin grafting to patients who clearly need it. This is not a small increase in skill or capability of the center, and I think is notable when they're offering skin grafting. And finally, center that actually has a burn unit leader, they're providing team care, they round together potentially, and they might even be training burn care professionals. So I think as you think about the center and your recommendations for improvement, it's good to know the wider network in either the region or the country that you're dealing with. And so considerations for improving rural and remote resource poor burn care. 1, do not devalue the care you're visiting. Number 2, learn about what they're already doing, their beliefs, common practices in both the facility and the community. 3, review wounds together, discuss and reach agreement on the principles of wound healing. 4, only consider sustainable options when suggesting an alteration in the current care that they practice. And finally, triage transfer and the electronic EMR available now on a phone, which would incorporate photos of the burn patients to help rounds. I am very happy to be here, and I thank you, and I hope that I have the ability to take questions.